Hello, everyone. My name is Mary Muko. I'm a specialist on the Provider Outreach and Education team at WPS Government Health Administrators. I will be your speaker today, and assisting me is my friend and colleague, Tom Ryan. We begin today's presentation, as we do all of our webinars, with this disclaimer. We include it in our education to inform our learners that we've made every effort to ensure that the education we provide is current and accurate. However, the information is subject to change. CMS publishes relevant laws, regulations, and rulings on their website, and answers to questions are based on the facts given, but CMS published instruction and their rules will always prevail, and these are what determines final Medicare coverage. Just as a reminder, CMS prohibits recording of this presentation for profit-making purposes. So just as advertised, this webinar today is really designed for entry level. I will provide a review of key points in the WPS GHA local coverage determination L37205, that's chemotherapy and their adjuncts. And I'll also provide timely topics that affect oncology providers, coders, and billers. And last but not least, I'll be providing some resources as well. If you'll look at the presentation materials, you will notice that I've embedded links to many resources that I'm going to talk about today during my prepared remarks. So let's start out with some information about Medicare's local coverage determinations and policies. These are actually defined, and the process is based on law, and that law is actually the Social Security Act, and I've included a link to that for you, where you'll find the definition of a local coverage determination on this slide. Interested parties can challenge a local coverage determination. However, there really is a specific process that must be followed in order to do so. And that process to challenge a local coverage determination is described in the Code of Federal Regulations, and I've included a link to that for you here on this slide. It is Part 426 of the Code of Federal Regulations. CMS describes the LCD process itself in their Internet-only manual. It is publication 100-08, and that's the Medicare Program Integrity Manual that is listed on the list of Internet-only manuals that CMS makes available on their website. All MACs follow the same process when developing a local coverage determination, and WPS actually provides a list of proposed and draft policies out on our website. Next, I'm going to provide just an abbreviated version of the LCD process for you. This is the process to finalize a policy, and it begins with an open meeting where anyone is welcome to attend and provide input while the MAC is developing that proposed policy. The Contractor Advisory Committee meeting follows a bit later when the draft is ready for their review. There's actually a public portion of this meeting when providers can hear about the policy as it's presented to the committee or any interested parties that want to attend that meeting. And the public is unable to comment at the Contractor Advisory Committee meeting. Only the CAC members are able to do so. But following the CAC meeting, then, that draft policy is tweaked by our policy staff, and the public comment period begins. The public comment period lasts for a minimum of 45 days. The formal comment period ends, and then comments are considered once again by the MAC. The draft policy is then published for what is called the notice period, and this is 45 days before the LCD actually takes effect. WPS GHA shows LCD status on our website. You can view a list of our local coverage determinations and the policy articles. Sometimes we call them the companion document that goes along with the LCD out on our WPS GHA website. We have a lookup tool available, and this tool allows the user to link directly to the policy in its entirety as it appears on the CMS website. You can only view an active policy in its entirety out on the CMS website. They're actually available in CMS's searchable Medicare coverage database, and you'll find links to both of those resources here on this slide. Now, based on CMS instructions in their internet-only manual, there are steps to follow if an interested party wants to request a revision to an active LCD. So this is a little bit different than a challenge. It's actually a revision. So we provide details and easy to follow instructions in a resource that's available out on our website. And I've included the link for you here. It tells you what needs to be included in your request and how to submit it and where to submit it and what you can expect. We have published a policy titled Chemotherapy Drugs and Their Adjuncts. The policy ID is L37205. And based on the instructions that I talked about earlier, each LCD, regardless of which MAC wrote it, includes all of the items that are listed on the slide. This is part of the components of an LCD that CMS provides guidance on. There is contractor information, and this identifies the MAC that published the LCD, the states in that MAC's jurisdiction, and if the LCD pertains to both Part A and Part B claims. The LCD and document information provides identifiers. What we're talking about here is the title, original and revision effective dates, and when applicable, other dates such as the notice period dates are included. This section also includes any related national coverage policy and CMS guidance on the LCD topic. Coverage guidance is where the MAC defines coverage indications, limitations, and or medical necessity, kind of the meat and the potatoes for the policy. General information includes any policy associated information, and what we're talking about here would be documentation requirements, utilization guidelines, sources of information, and then sometimes a bibliography is included here. Revision history provides a revision history date, the number of that revision, explanation and reasons for changes that occurred due to the revision. And this would include those yearly reviews that are required by CMS that our policy staff undertakes. We are required to provide an annual review of our local coverage determinations. Sometimes there's a change, sometimes there's not, but regardless of that, these required reviews are actually included in that revision history. Associated documents then are any related billing and coding articles or related national coverage documents. And finally, keywords are just that. Many times these are not even applicable. There's no keywords included. So there are actually two related local coverage documents for the chemotherapy and their adjuncts local coverage determination. They're shown here on this slide. One is A55639, that's billing and coding chemotherapy agents for non-oncologic conditions. And this article is not intended to be a complete list of drugs that may be administered using the chemotherapy administration code, but it really addresses the anti-neoplastic agent codes that are provided for treatment of non-cancer diagnoses or to substances such as monoclonal antibody agents and other biologic response modifiers. Another related local coverage document that's included that you can view is A55641, and in that particular article is the response to the comments that WPS-GHA received during that LCD draft process and the process to finalize our policy. So this summarizes the comments that we received for the draft policy called Chemotherapy Drugs and Their Adjuncts. So again, this would be all of the comments that were submitted to us. We do provide a response to those in this associated document. So then, what does WPS-GHA base coverage of chemo agents on? This slide actually explains or lists that information that WPS uses to determine coverage for chemotherapy agents. And the expectation is that there is documentation to support this. This would be the patient's condition, diagnosis, the appropriate dose for the chemotherapy drug. We're also going to be taking a look at the route of administration. And last but not least, medical necessity. And local coverage determinations, as with any type of policy, whether it's a local policy or draft policy, actually define medical necessity. And policies means that there are edits in the processing system that occur when that given procedure or item is billed to the Medicare program. So this information then is taken directly from the LCD. I just simply cut and pasted it into this slide or onto this slide. And based on the local policy, WPS considers chemo agents to be covered if, of course, reasonable and medically necessary. That medical necessity would need to be met and documented in the record. And the drug is FDA approved. And the drug is listed in the National Comprehensive Cancer Network, or NCCN, clinical practice guidelines in oncology, but it must be listed with the specific ICD-10 diagnosis, that is the one being treated, for the drug or agent. The chemotherapy agent must be listed, as you can see on this slide, in category 1 or 2A in the NCCN, and the chemotherapy agent must be utilized per the NCCN recommended use. So in other words, all of these need to be met, not just some of them, all of them. That's why the word "and" is added to each of these lines, and it's bolded. Currently, there is a targeted probe and education or educate or TPE process going on in both of our MAC jurisdictions. That's Jurisdiction 5, which is the states of Iowa, Kansas, Missouri, and Nebraska, and Jurisdiction 8, which is the states of Indiana and Michigan for Infusion Services. You can find details about the review process on our website. And this includes on our website a resource titled Infusion Services. There's a link to it here on this slide. And this article provides documentation and coding guidance for a successful review. We also include in that resource some CMS Internet-only manual resources and other resources, and those are at the near the end of that particular resource that you can find. If your claim is selected for TPE, we will offer one-on-one education on any identified errors at the end of each review, and we do encourage providers to take advantage of this opportunity to discuss review findings with the nurse that actually performed that particular targeted probe and educate review. When scheduling education about our policy and about oncology, I went to our medical review staff and asked them if they have any recommendations in relation to the TPE findings for infusion services. And it appears that the big takeaways, at least for the past few months from medical reviews, are to make sure you're billing the correct code in relation to infusion time. Some of them that were submitted and reviewed, or some findings, are that they were overbilling. Ensure that there is a provider order for all of the medications that are being given. Sometimes we're not receiving that order when we're looking at the records for these reviews. Make certain to bill for the correct date of service. And then, of course, be aware when hydration can be separately billed. One of my provider outreach and education colleagues, she's a nurse analyst, Mary Sue Gardner, will be hosting a webinar titled A Deep Dive into Medical Review Findings on Infusion Services. And that's going to happen next week on Friday, December 22nd. And it's scheduled to be held 10 a.m. to 11 a.m. Central Time, so 11 to noon Eastern Time. You can find more details by selecting the link that appears for this event on our live events webpage. And I'll ask Tom to place the link for this webpage into the chat so you can find that information if you're interested in finding details on the webinar that Mary Sue will host next week that is specific to the medical review findings for infusion services. Next, I'm going to talk a bit about Incident 2, and Incident 2 is a Medicare payment concept. It's not recognized by all payers. Incident 2 billing allows a non-physician practitioner and auxiliary personnel to report services as if they were rendered by a physician or non-physician practitioner. And so for this reason, it is really important that Incident 2 rules are followed exactly. Doing so potentially increases patient access to providers, and it can also enhance revenue opportunities for providers and clinics. This slide lists the CMS Incident 2 criteria, and this information is taken directly from the Internet-only manual section that was mentioned on a previous slide, or the previous slide, I should say. First of all, the service that is being rendered must be a professional service. It is the type of service that a physician usually renders in an office setting. The location for Incident 2 is that it must be a non-institutional setting, and in the Internet-only manual, CMS states that this means all settings other than a hospital or skilled nursing facility. The next criteria is that an employment relationship must exist between the provider who's billing and the rendering individual. The billing provider must employ the rendering individual, or they must both be employed by the same group. Just as an added note, the rendering provider could be a leased employee, could also be a contracted employee, but there is an employment relationship that exists. The next criteria is that the billing provider must initiate the plan of care. If documentation is requested, there must be evidence that shows that that billing provider remains actively involved in the care of the patient or in the management of the patient. Now, if during that encounter the service that's being rendered deviates from that plan of care, then that service is no longer considered an incidental service, and Incident 2 services may not be billed. Now, there may be some situations when the rendering provider is one who is enrolled with Medicare and eligible to submit claims to Medicare, that he or she can then submit a claim for direct payment, but it is not covered under Incident 2 when the service deviates from that billing provider's plan of care or Incident 2 services. And finally, the last of the 5 CMS key criteria for Incident 2 is that the services must be furnished under direct supervision of the billing provider. And that means that there must be direct supervision for the entire duration of that patient encounter. The provider who is supervising has to be in a proximate location to the rendering provider. This really means that the billing provider is present in the office suite or in the proximate area. One of our former contractor medical directors actually coined the phrase speaking loudly distance, and I think that describes it well. I was at a partner event once upon a time, and one of the individuals in the audience suggested holler down the hall distance, and I think that works well also. So one of the things I want to mention to all of you, since today's presentation really is focused on oncology services, is that for those services that are being rendered in an infusion center, make certain that supervising physician or NPP, if it's a non-physician practitioner, is in proximity. If he or she has not yet arrived at the infusion center, then the service can't begin as an Incident 2 service. If he or she is stuck across town in traffic or out in the parking lot, parking the car, the service is not incident to. So I know that typically you schedule your patients at such and such a time to begin infusion. You need to make certain that that supervising physician or NPP is in proximate location when that infusion service begins. All right, we're moving away now from incident to talk a little bit about telehealth services. Medicare will allow the services that appear on CMS's list of telehealth services. The services on the current list that's published on CMS's website, and it's linked there on this slide for you, are good as telehealth services through December 31 of 2024. And CMS actually just recently updated that. Back when the the Consolidated Appropriations Act of 2023 was published, it seemed to extend some flexibilities for telehealth services through 2024, but now CMS has actually published that list of services. I mentioned here on this slide, any changes will occur through the 2024 proposed and final rule, and this is true, but it's already happened. When we prepared the presentation, the final rule hadn't finalized yet, but those changes did actually occur through the 2024 calendar year 2024 physician fee service final rule. I'll ask Tom to place a link to the fact sheet for that final rule in the chat so you're able to find this information later if you're interested in looking at it. That is those specific changes that were updated for 2024. We held a webinar titled Telehealth and the End of the Public Health Emergency. This was recorded, and you can find a link to this here on this slide. You might be interested in taking a look at this. This is a recording that does continue to be housed in the WPS GHA YouTube channel or on our channel if you're interested in looking at that. All right, next up is JW and JZ modifiers. I want to talk about this a little bit and tell you where you can find a bit more information. When providers discard any portion of a single-use vial or a single-use package after administering a drug or biological to a Medicare patient, they must use the JW modifier to indicate any quantity that was discarded. And effective July 1 of 2023, providers and suppliers are required to report the JZ modifier on all claims that bill for drugs and biological from single-dose containers that are separately payable under Medicare Part B when there are no discarded amounts. CMS has published frequently asked questions about these modifiers, the JW and the JZ. If you have questions about use of these modifiers, you should refer to this frequently asked question document. If you're unable to find an answer to your questions, then we would recommend that you direct your inquiry to customer service, where someone in that department can properly log, track, and respond based on CMS instructions. We have also hosted, just not too long ago, some webinars on the use of the JW modifier and JZ modifier. I can't even begin to go into all of the if, ands, or buts during this presentation designed for entry-level coders, billers, and staff. But the speaker did a really great job explaining how to use these modifiers or when you need to report these modifiers on your claims. That information is available out on our WPS YouTube channel. And on this slide, I've actually got a link to the WPS GHA YouTube channel. I mentioned earlier to you that we record all of our presentations. You can find a list of presentations. We keep them on our website, on our Encore Presentations webpage for 90 days following the live event, or for about 90 days, about 90 days from the time we post it, or the live event date. And then we also at the same time publish that recording out on our YouTube channel. But once the encore presentation is removed from our web page, you'll find the information out on the YouTube channel where it will remain until there is a decision to remove it. You know, maybe something has changed, or maybe we find that an update is necessary, so sometimes those have to be removed from the YouTube channel. I want to talk a little bit about NOC and new drug pricing. CMS provides drug pricing guidelines, and they do this in their internet-only manual. It's publication 100-04, specifically Chapter 17 and Section 20.1.3. We have published an NOC drug and radiopharmaceuticals pricing resource out on our website. The link is here for you. For the Chapter 17 of the manual, but the resource on our website explains that if a drug is not subject to a special payment calculation or exception, max-based drug payment on 106% of the wholesale acquisition or the wholesale acquisition cost, or WAC. I got ahead of myself there. When there is no WAC pricing available, then WPS requests an invoice. This slide provides some information about invoice pricing, and when pricing by invoice, MACs allow the cost of the billed drug, a prorated amount for shipping and handling, and any applicable sales tax. CMS grants no additional percent when pricing is by invoice, and they allow no payment for dispensing and compounding fees. If you bill for an item that you know, or a drug that you know WPS prices by invoice, then we suggest that you consider using the PWK segment on the claim. So you may be asking, what is PWK? PWK stands for Paperwork Segment, and this is a segment on an electronic claim that provides a link between the claim and the needed documentation to process the claim. The segment must be populated at the time that you submit your claim or when it's sent. And when used correctly, there's no need for WPS to suspend processing of the claim in order to send that additional documentation request or ADR letter to the provider. So use of this segment, the PWK segment, can save time, and it often leads to faster processing of the claim. We have a helpful resource on our website that does a really good job explaining the required steps to use the PWK segment on a claim. And for those of you not using this, this can be one of your number one takeaways from this webinar today, is to go back and take a look at this resource that I talked about. It's called Additional Documentation, Ways to Reduce Your Burden. This really is a game changer based on the feedback that I've heard from those that prepare and submit claims for chemotherapy drugs. So remember though that use of the PWK segment is not appropriate once your claim is submitted. It's only appropriate when that PWK segment, and again, the resource tells you how to use that segment on your electronic claim. It's only good when the PWK segment is populated at the time your claim is submitted. So something good to check out following this event, or this live webinar today. This slide is included because WPS continues to receive claims for beneficiaries who have elected Medicare Advantage or Medicare Part C instead of fee-for-service, traditional, or original Medicare. This is often referred to as health maintenance organizations or preferred provider organizations. That's what we're talking about here when we say Medicare Advantage or Medicare Part C. Those claims should be submitted to the plan and not to the MAC. The MAC is your Medicare Administrative Contractor. WPS GHA is the MAC for Part A, Part B, claims for Jurisdiction 5 and Jurisdiction 8. So again, you need to contact the plan if you have questions about coverage on a claim for a patient who has elected Medicare Advantage, Medicare coverage in lieu of or instead of Part A and Part B, traditional or original Medicare. There is an MA plan directory available on CMS's website. Very helpful for you when you are checking eligibility for Medicare beneficiaries. If there shows a plan ID for Medicare Advantage, that plan ID number will show up in this MA plan directory, and it's helpful because it provides the contact information you need for that particular plan. So you kind of have to use both of them together, both the information out on eligibility if you're using the transactional portal on our website, or you're using information that you get from the integrated voice response. Many claims being submitted. We receive many phone calls in our customer service area, but the question is for patients that have selected, or often the question is for patients who have selected a Medicare Advantage plan. We unfortunately can't help because we don't know the coverage for the plan. We know, and we tell providers, that Medicare Advantage plans must offer the same basic benefits as traditional Medicare or original Medicare, but they can also offer more. So questions about Medicare Advantage have to go to the plan, not to WPS GHA. Out on our live events webpage, in addition to viewing a list of our upcoming live events, we have placed a timely topics document, or a link to a timely topics document. We update this document quarterly. There's often some valuable information in that document that may pertain to you, so I would recommend that you take some time to look at this document, at least on a quarterly basis. A couple of these other things listed here are those that I've mentioned already, the playlists and videos out on the WPS GHA YouTube channel. Just another great way for you to stay informed about things that both CMS and WPS want you to know about. If you do not already, please subscribe to our e-news and read it. Don't just subscribe. Make sure you're opening those messages that we send out. Very valuable and pertinent information. If you've not already subscribed, you can easily do so. Go to the WPS GHA website. At the bottom of every page, there's an opportunity for you to enter your email address in order to begin the subscription process. And just a reminder, if you need presentation material, maybe you missed a live event. I told all of you earlier about the Infusion Services webinar Mary Sue will host next week, Friday. I know it's December 22nd. There's a lot of people who take off around the holidays. If you're not able to be there, you can find the link to the encore presentation following her live event out on our website, and of course you'll find that information also out on the WPS GHA YouTube channel. The next portion of the presentation is some time that we're allowing for questions, but I did receive a number of questions that were pre-submitted. When you registered for today's event, there was a question that said, what is the one takeaway or the one question that you have? And I did receive some, and I want to make certain that I cover all of these for you. So the first question, or one of the questions out there, I don't know if it was the first one, is when is an evaluation and management service supported with radiation therapy? And it is in the National Correct Coding Initiative Policy Manual for Medicare Services, specifically Chapter 9, where CMS covers radiology services. Those are those with CPT code 70000 through 79999. There is a section on radiation oncology in that manual, and in the manual it states that except for an initial visit, evaluation and management, or E&M service, at which the decision to perform radiation therapy is made, E&M services are not separately reportable with radiation oncology services, but there are some exceptions, and it is in that manual that the exceptions are listed. And what I will do for you is following this event, I will send an email out that has the link to Chapter 9 of that NCCI policy manual for Medicare services so that you can see this information there and you can see those exceptions. I will include links to more resources that I'm going to talk about here in the next few minutes also. So the next question is, do services always get billed under the ordering physician, or are they supposed to be billed under the supervising physician for that date of service? The charge really on that claim represents the service of the provider that's submitting that claim. So that's the supervising physician. And in the case of a service that's provided incident to the service of a physician or non-physician practitioner, when the person who ordered the service is not the supervising physician, then you need to enter the NPI of the supervisor in the lower unshaded portion of item 24J or the electronic data equivalent. So you can find this information that says you need to enter the NPI of the supervising physician. You need to bill it under the supervising physician. So if the regular supervising physician, the one that wrote the plan of care, wasn't available on a given day, maybe day off, vacation, illness, if someone else is in the same clinic and steps in for that individual, the service needs to be billed under the individual that rendered that service. So the Medicare Claims Processing Manual in Chapter 26 includes completing and processing Form CMS 1500 dataset instructions. So this provides for you that information that I just told you, saying that you need to enter the NPI, the National Provider Identifier of the supervisor, in the lower unshaded portion of item 24J. So I'll include a link to that, or that chapter, in the Medicare Claims Processing Manual when I follow up in an email following this event. For those of you that submit electronically, and it is most of you, I am certain of that, we do have a crosswalk that crosswalks each of the items on the CMS 1500 claim form over to the electronic claim. And I'll include a link to that crosswalk. It's out on our EDI website when I send you the follow-up email with all of these resources pertaining to these great pre-submitted questions. The next question is, what will CMS be focusing on for areas of review for oncology? I talked a little bit already about targeted probe and educate. CMS authorizes the MACs to conduct TPEs, or targeted probe and educate, and these are reviews. And this is done when data analysis indicates potential aberrancies related to that service or that item. So we do have a current TPE process going on in both jurisdictions 5 and 8 on the infusion services. We do have an article on our website, or a resource rather, that focuses on that, tells you the coding rules, the billing rules and such. And this is the review that I was telling you about that Mary Sue is going to talk about next Friday. She is going to provide for you some of the review findings and talk about those. So some good information. I will include the link to that article. I think it's actually in the PowerPoint already, but if I've not already done so, I'll give you the link to the resource. The other question was use of modifiers JW and JZ, single dose vial billing. And I've already talked about this already. We have CMS prepared questions and answers that are available. And you can also view the Encore, it was a Modifier Monday correct use of modifiers JW or JZ video on our YouTube channel. If you take a look at those and you still have unanswered questions, then I would recommend that you contact customer service and someone will assist you with your questions. The next question is, can chemotherapy be billed the same day as discharge from the hospital? So if you're billing for administration, what I would recommend is that you check the National Correct Coding Administration procedure to procedure edits, and I'll provide the link to that when I follow up in an email. You know, you need to check each of the CPT codes you're billing to see if they are able to be billed together or a payment can be unbundled. But just because the modifier indicator on that procedure to procedure edit table shows that you can unbundle them, there's another step. You need to make certain you're checking your documentation to make sure that the documentation justifies the use of that modifier to unbundle payments. So just something to keep in mind. The other consideration may be the date of discharge from the facility. And from what I understand, and I asked a colleague for input, she understands it the same way. Medicare does not pay the discharge date as part of the covered days. So I don't think that we would edit the outpatient service or that clinical staff service and drug against the inpatient. However, if there is a denial for the patient being inpatient, you can request an appeal. What you would need to do is submit that documentation that shows the date and the time of the discharge, and then of course the date and the time for that administration of the chemotherapy. The last question that was pre-submitted or submitted during registration process is, what's the easiest way to code chemotherapy services? And that's a very, very good question. MACs are actually prohibited by CMS from offering coding advice, so we can't tell you how to code your service. We can provide for you billing and coding guidelines, but we can't tell you this is how you have to code something. The way I would answer this is that if you're seeking help for coding chemotherapy services, check the resources that are available on the WPS and CMS websites. There might be some guidelines published to help you, although we can't look at documentation and tell you this is how you have to code it. We can provide advice and guidance. Another suggestion would be to look at the WPS GHA YouTube channel. There may be some things out there that might be helpful. And the last consideration or thing to think about, and I've often provided this recommendation to people, is consider reaching out to your local professional societies or organizations. Many of them have ways to help. Or they have websites where you can submit a question and members will provide answers to you. So that may be helpful also for you. Next, I'm going to throw it out to Tom for just a moment to see if there's any additional questions that may have come in.
Mary, we do have one question that was asked in the chat, and it's, are we still able to perform the direct supervision virtually through the end of 2024?
Oh, that is a good question, and I am going to need to follow up on that specifically. I do need to brush up on the guidelines that were implemented following the publishing of that final rule in November. I gave you a link that would provide that answer for you, but I will follow up with that very shortly after today's webinar. I'm not really certain about that, I have to be honest with you, but I will check and I will get you the right answer. Tom, is there anything that you'd like to add today? I know you have a lot of a wealth of knowledge about happenings in Medicare.
No, actually I do not. Just remember to register for those other live events that may affect you, but other than that, that's all I have. No other questions submitted.
Terrific. Well, one of the things that I can tell you is happening, and it's something that I talked about with the medical societies in a meeting with CMS just a couple of days ago, is the transition to the provider enrollment chain and ownership system, or PACOS, the online enrollment system. There's version 2.0 coming up. CMS is working diligently to roll that version out. It will be a much better product for you when that happens. So keep your eyes and ears open to find updates on that transition over to PAYCO's 2.0. I know that one of my colleagues has been offering a good deal of education on that happening. So it's just something to be aware of, that that is changing if you are one of those folks that is involved in the enrollment of your staff. Thank you for your participation. We look forward to your survey comments, and we hope to have you join us for future events. Thanks, everyone. You may now disconnect.